Okay, good afternoon, everyone. Thank you for joining today's national webinar, Developing and Sustaining Sobering Centers, Perspectives from California. My name is Meryl Schulman. My pronouns are she, her, and I'm a senior program officer at the Center for Healthcare Strategies, or CHCS. Lines are muted for today's event, and but you can ask a question at any point through the Q&A function located at the bottom of your Zoom screen. Also, please note that slides and the recording of today's event will be posted to CHCS's website and sent out to all registrants. I'd like to begin today's webinar by expressing my gratitude to our colleagues at the California Healthcare Foundation for supporting today's webinar, to you all for joining us, and to our incredible lineup of speakers, whom you'll be hearing from shortly. As alluded to in the title of today's event, this webinar will highlight an array of sobering centers in different communities in California, how they were developed, how they operate and are staffed, and how they are financed. We'll also hear updates on what's happening more broadly in California and even nationally as the field of sobering care continues to grow and evolve. Next slide, please. So I want to take a step back and share about CHCS for those not familiar with us. CHCS is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for kids and adults served by Medicaid. Since 1995, we have worked in every state in the nation, and we partner with an array of stakeholders like states and federal agencies, health plans, providers, community-based organizations, and consumers to make healthcare work better for those who face serious barriers to well-being. More specifically, we work to advance more effective models of care delivery, more efficient policies and programs, and across all of our work, more equitable care and outcomes. From my perspective, sobering centers are one of those effective and innovative care models that allow communities and systems to better connect people to the care they need while also maximizing the use of finite resources. Next slide, please. So on this slide, you can see our agenda for today. Here we are at Welcome and Introductions, and in a moment, you're going to hear from my colleague Melora Simon at the California Healthcare Foundation about the work that they've been supporting related to sobering centers. We'll then have about 35 minutes of panel discussion, and then we'll have ample time for audience Q&A before rounding out today's event. Next slide, please. So I mentioned that we will have time for Q&A today. As questions come to mind, please drop them into the Q&A function located at the bottom of your screen. And for those of you who may have joined the webinar late, this event is being recorded. The recording, slides, and materials will all be shared out with registrants and posted to CHCS's website following today's session. Next slide, please. Okay, so I've been talking about sobering centers in my opening remarks, but what actually are sobering centers? In short, sobering centers are short-term facilities located in the community that provide care to people who are intoxicated. They typically operate 24/7 and are open 7 days a week. Sobering centers are often designed as an alternative location to jail or the emergency department, where adults under the influence of drugs or alcohol can safely sober up. Folks residing at a sobering center are monitored. They often have a comfortable place to reside, like a bed or a recliner. And often there are case management or support services that can connect people to resources or additional healthcare services like substance use treatment, mental health treatment, should they want or need it. The idea of sobering centers is that they give people a safe place to be while they are intoxicated. They also serve as a point of intervention or connection for folks with substance use or other healthcare needs. And they save our healthcare and criminal justice systems resources as folks are diverted away from hospitals or local jails, which are often overburdened. As we dive into today's session, you'll learn from our speakers that sobering centers come in different shapes and sizes. They can have different staffing models, different community partners that support or refer to them, and they can be tailored to the needs of a community. Next slide, please. So you've already met me, but in a moment you'll hear directly from my colleague, Melora Simon, who is the Associate Director of Complex Care at the California Healthcare Foundation. I'll then be inviting up our panelists for today, Jamie Campos, who is the CEO of Horizon Treatment Services, Amanda Rago Carnegie, who is the Divisional Director of Residential Treatment Services at Behavioral Health Services Incorporated, Sylvia Bernard, who is the Executive Director at Good Samaritan Shelter, and Shannon Smith Bernardin, who is the past president and co-founder of the National Sobering Collaborative. We can go to the next slide, please. So now, without further ado, I'd love to turn it over to Melora Simon at the California Healthcare Foundation. Melora is going to be offering a few opening remarks on behalf of the foundation, and she'll also be talking about new resources that the foundation commissioned to support the implementation of sobering centers. It's all you, Melora.
Thanks so much, Meryl. For those of you that don't know us, the California Healthcare Foundation is an independent nonprofit philanthropy that works to improve the healthcare system so that all Californians can have the care they need. We focus especially on making sure the system works better for Californians with low incomes and for communities who've traditionally faced the greatest barriers to care. We're leaning into sobering centers because we believe that sobering care is a really critical part of having a low barrier system. So with that in mind, there are two important resources that we just published that I wanted to highlight. The first, which is called Sobering Centers Explained, an environmental scan in California, shows how the landscape has transformed since our first explainer was published back in 2021. It demonstrates how California continues to lead the nation with sobering centers now operating in 16 counties across both kind of diverse geography and demographic settings. And it captures important lessons learned from both established and newly opened sobering centers and highlights some important policy developments, including CalAIM, California's major transformation, and how sobering care as a part of the community supports program and evolving legislative efforts have reshaped how these centers are funded and operated. The second resource, which is called the Blueprint for Sobering Care in California Implementation Guide, which is published just this week, is more tactical. And it's really designed for community-based organizations, managed care plans that are contracting for sobering care under CalAIM and other stakeholders. It provides three things that I think are super important, like practical tools, financial planning resources, and real-world examples for both new and existing centers to make implementation easier. Finally, I would be remiss if I didn't mention a really exciting development. So national accreditation is on the horizon. This is important because it's a pathway for sobering centers to be an alternate destination for EMS, which we'll hear about from the panel. But we're so excited that the Commission on Accreditation of Rehabilitation Facilities, CARF, and the National Sobering Collaborative have launched the nation's first accreditation program for sobering care, which established national standards for quality in care. We're expecting that those standards will be published in January with accreditation available in June. So I'm so grateful to the team that put together these resources and so excited to learn from our panel. And I'll turn it back over to Meryl so that we can get into it.
Thanks, Melora. So we will now transition to our panel discussion. I'd like to invite Jamie, Amanda, Sylvia, and Shannon to the screen. Just so folks know, we're going to keep the slides up for a moment, and then eventually we will drop them as we move further into our conversation. And as a reminder, Jamie, Amanda, and Sylvia are all operators of sobering centers in different communities in California. And Shannon not only has experience developing sobering centers, but she also founded and served as the president for the National Sobering Collaborative, which is an organization focused on developing and disseminating research, best practices, education, and policies to help develop and sustain sobering centers nationally. Each of our panelists will be sharing more about themselves and their sobering centers momentarily, and we invite you to settle in with us for the rest of the hour and to learn more about sobering care. So I'm going to start. I, I'm going to start maybe with you, Jamie. I'm going to ask each of our panelists to introduce themselves and to also share a snapshot of their program. And Jamie, I'll turn it over to you to go first. And we can go to the next slide, please, Emily.
Yeah, thank you. Hi, everybody. I'm Jamie Campos, CEO of Horizon Services. Horizon is a California 501c3 nonprofit behavioral health provider operating a number of different types of programs across the continuum of care in multiple counties in California. We operate in about 4 different counties in California and recently have expanded into New Mexico. So we're really excited about that. But we're really just so passionate about sobering care. We've really seen how these programs can reduce the burden on emergency services and help our clients link to the care that they need. But we have about 4 different sobering center programs and designs. And as you can see here on this slide, they're all wildly different. These sobering programs are just unique to the communities which they serve, right? And so, you'll find that as you look at different programs, they all have their unique features based on what the community is grappling with and really what the needs are. But our Cherry Hill program in San Leandro in the Bay Area, California, has a pretty high capacity, but we usually do about 25 admissions a day. In terms of funding, it pulls from some local tax revenue, essentially, and that's been operating for over 10 years now. But we mainly contract with a primary payer, so we have our county behavioral health entity that will oftentimes come in as the primary payer and then bring in some additional maybe subsidization. And as many might know on this call, under CalAIM, community supports funding can support sobering centers today. So over the last couple of years, we've seen our county entities start to maybe subsidize a little bit of the sobering center cost by leaning on the managed care plans in their regions. But in terms of admissions criteria, you usually have somebody who is under the influence of drugs or alcohol. It's important for them to be ambulatory, carry out their activities of daily living. These are voluntary programs, and we have our medical directors who will establish some thresholds in terms of vital signs. So we really care that the programs are low barrier, open access, as we heard earlier on the call. But we do have some safety parameters, right? So we really want to make sure that the individual is not really more appropriate for a higher level of care. So there's some of that screening that happens. And so you'll see some of those common features of sobering programs across different types, as you can see here on this slide. Our more recently open program, Butte County, so this is in a rural region, Northern California, is a 12-bed program. And what's cool about this one is that this one started just last year with the Butte County Behavioral Health Division as the primary payer, but Horizon basically bills the Partnership Health Plan of California. That's the managed care plan under community supports first. So we bill the managed care plan first, and then the county comes in as the payer of last resort, covers the rest of the cost of the sobering program. And so there you can see CalAIM basically in action, right? Sprouting up new sobering programs because of that subsidization, thanks to that CalAIM initiative. And just right out of the gate, I mean, we just really saw some really nice utilization for the Butte County Sobering Center. And that's really just attributable to the open access, low barrier nature of the program. In Mission Street Sobering Center, you'll see here on the right-hand side, is a 20 recliner program. So when that program opened in 2017, it hit the front page of the newspaper because you had recliners that they were trying to kind of position this as like, gosh, they're bringing people that are under the influence and just kind of putting them in recliners. And so like the community really cared about like, what is this program? Like, what is it trying to do? But that's really been a successful program that initially started under a whole person care pilot, as some of you might remember back in 2017. But now the county has picked that up after that pilot has ended. And it too is subsidized with other types of funding. So you'll see different funding mechanisms at play with soberings in order to make them successful. And I think you'll see that in the CHCF report that was highlighted just a second ago. But pretty similar admissions criteria. But what's unique about the Mission Street Sobering Center is that it also serves the mental health population, right? So you don't necessarily have to be under the influence at Mission Street Recovery Station. It'll receive some linkages from the crisis stabilization unit in the community. So once somebody has been stabilized, they'll come on over to the sobering center, get some quick stabilization, and then some additional linkages to the continuum of care. Well, we can go to the next slide. Referring parties is an interesting topic, right? Because sometimes sobering centers start off as a really heavy law enforcement focused program. So you have these deep partnerships with law enforcement entities. They're really after some quick drop-off times, right? So that's really important. You can usually get somebody processed within a 7-minute turnaround time with your law enforcement officers. So that's important to them because in comparison to a jail booking, which oftentimes takes over an hour, they can get back to some other community policing matters that are just more pressing in nature, right? So there's an improvement to community safety in that regard. But our programs are pretty different in terms of which programs lean towards serving law enforcement, like heavily law enforcement, referring party focused, versus open access, come on in, walk in. The majority of the utilization is actually walk-in utilization. So we're seeing that at Butte County, whereas let's say Mission Street Recovery Station is focused on heavy law enforcement linkages, and that's how the program started. So there's some variation there. And in terms of staffing, it's pretty common to have LVNs, EMTs in the staffing models for Horizon programs, registered or certified drug and alcohol counselors, case managers, because we know how important it is to make those linkages to the system of care once somebody comes into your sobering center, and various services provided: food, water, hygiene, laundry services, showers, right? So our clients really, really value that. And then lastly, the Gateway Medical Sobering Center on the bottom that you can see in purple. This has been a more recent grand opening in October. So this just kind of hot off on the press. Like you got this Gateway Medical Sobering Center in Albuquerque, New Mexico. So this was a great partnership with the city of Albuquerque, 50 recliner program. And it's got a few unique components in comparison to the other 3 programs that I presented. But essentially, it's a medical forward program, right? So it's got a registered nurse leader, a nurse practitioner is embedded as part of the treatment team. It engages in MAT prescribing because of that nurse practitioner. So that's really a value add. And it's also focused on some of the EMS drop-offs. So you heard a little bit about that earlier, a little bit of a rarity in California. So we're really excited about CARF accreditation, which will help open that opportunity up in California. But in Albuquerque, that was really a kind of a big vision for that program. And just recently, our EMS drop-off protocols were approved. So we'll start to see some improved utilization and help get some ambulances, EMT crews, fire department crews some time back. So really, really excited about that. We're seeing about 5 admissions a day of utilization, and the program opened early October. So really, really good progress in that sense. And I'll turn it over to the next presenter.
Thanks so much, Jamie. It's interesting to just see how, like, even among the different programs that Horizon operates, how different they are. So now if we could go to the next slide, I'll turn it over to you, Amanda. Would love for you to just share a little bit more about yourself and a snapshot of your program.
Absolutely. Yeah, I am Amanda. Like I said, I'm the divisional director over some of our programs here at Behavioral Health Services. We're a really large conglomerate in LA County offering the full continuum of substance use care, some smaller mental health contracts, and primary clinics. And our Sobering Center is actually our newest program. We opened about 3 years ago, part of the Martin Luther King Hospital campus. They renovated the campus and created a behavioral health center that our sobering center is located in, which is really great for our program because it is physically integrated with all of these other services. There's a PUF unit on the campus, outpatient mental health, a peer resource center, residential treatment, outpatient treatment, any service you can think of that relates to behavioral health is all right there for our clients to access. And our sobering center oftentimes serves as the entry point for clients to begin receiving all of those other services that are located there. So our sobering center, again, really values that maximum flexibility and low barriers to access. We're a smaller sobering center, only 12 beds, adults of any gender, but we are co-located with a 3.2 residential withdrawal management program. So the vast majority of our sobering clients actually transition into our detox unit that is located in the same building to make it really easy for them to continue on in care if they choose to. And that's supported whenever possible for our clients when they have the need, when they have the desire, really easy for them to continue on in care. We serve the public at large regardless of their insurance, demographics, other factors. But what we see most often in LA County, especially in our particular location in South Los Angeles, are vulnerable and otherwise underserved populations. So I would say maybe 85% of our population are unhoused. We have very many undocumented folks that we treat in our programs, individuals with chronic substance use, co-occurring mental illness, and medical challenges. And then we do have an interesting partnership with TSA. So we actually see, quite a few business people from LAX airport that are too intoxicated to get on the plane. So really hitting the full gamut there, but primarily working with the underserved community. Participants in our program can remain just like most sobering centers for up to 23 hours and 59 minutes before transitioning back into care or back into the community. And with our program, again, a lot of them do transition onto our withdrawal management unit. And we have no limitations on readmission, which we think is a strength. We see a lot of returning clients, which for our impression makes us think that they feel safe and feel cared for in our environment. So we see that as a really positive thing. You can go on to the next slide. So we are like other sobering centers, open 24/7, 365. We have a really wide array of referral sources, which I'll get in more to later in the panel, but from walk-ins, other treatment providers, community providers, our new EMS designation, which we started in September of this year, and law enforcement. Our EMS designation, which I'm sure I'll speak more on later, allows us, as Jamie said, to receive sobering center referrals directly from emergency service providers like paramedics, police officers, first responders, the fire department, et cetera, to really cut down that overcrowding, which is a big problem, especially in Los Angeles County in jails, in emergency departments when they can better be served in a treatment environment. We are the only current Southern California EMS designated sobering center, with San Francisco being the first. And I know that that designation is expanding to other sobering providers across the area. So we're really excited to see that. Our admission criteria, we do only serve adults in our sobering center. They must be medically cleared, so no uncontrolled acute medical issues, uncontrolled diabetes, for example, open draining wounds. We are fortunate to be on the campus of a large hospital, so we have a lot of clients who come in for treatment, have to potentially go to the ER to urgent care first to get their medical needs treated, and then come right back to us for sobering care. Obviously, persons have to be intoxicated or reacting to substances, free of related legal charges, so they can't be, escaping charges in order to receive treatment with us, and voluntarily seeking sobering care. We do not take people that are on 5150 holds. It is a voluntary program. And individuals are excluded for us if they have, as I said, unstable or urgent medical conditions that require treatment first. Advanced medical intervention, are unconscious or unable to otherwise communicate, cannot self-transfer, or have a blood alcohol content above 0.35. Our sobering center staff, it is a requirement of our EMS designation that we have 24/7 registered nurses so that the clients can receive the care that they need. We have our registered nursing supervisor who oversees both the sobering program and the withdrawal management program, and she is our emergency medical service liaison for that designation. We also have security ambassadors, as we know safety can be a challenge in the sobering center. Our security ambassadors serve as dual roles because they are also peer support specialists. So they, engage with the client, support them in making sure that they feel safe, that they're behaving safely, and receive that additional peer support that they may need. Our program is overseen by a master's level clinician who is also a certified SUD counselor. He oversees both the sobering center and our withdrawal management program, along with shared office support and a registered nursing supervisor. And then we're, of course, provided with oversight from a medical director who supported our policy development, is available on call for consultations as needed. Our co-location allows additional licensed vocational nurses, SUD counselors, certified peer support specialists, which I'm really passionate about putting in as many of our programs as possible, and clinicians. And while they don't deliver formal services in the sobering center side, clients in sobering center are aware that they have access to those services should they continue in withdrawal management. And our program overall is managed, as I said, by BHS, and the sobering center is funded directly by the county substance use prevention control.
Thanks so much, Amanda. We've already got a bunch of questions that are trickling in, so I'm looking forward to the Q&A in a little bit. Just one clarifying question. A participant was asking, a participant acknowledged that you mentioned detox, and they were wondering if you were referring to withdrawal management specifically.
That's correct. Yeah, we have a 3.2 withdrawal management. So that is a clinically managed residential level of care, and it is co-located. So those programs are in the same building, work directly to refer persons back and forth, and then externally along the continuum of care for clients that choose to continue with their treatment. So it's a really nice arrangement that works really well, both for referral streams for us and for those clients to have an access point to continue care if they want to do so, because our sobering center isn't standalone.
Thank you. So we can go to the next slide, and Sylvia, I'll turn it over to you. If you could introduce yourself, Good Samaritan Shelter, and a snapshot of your programs.
Yeah, so I'm the executive director of Good Samaritan Shelter. I'm Sylvia Bernard, and we are the largest homeless services provider on the Central Coast and the largest drug and alcohol treatment provider, SUD providers here in Santa Barbara counties, also serving San Luis County. We opened our very first 12-bed sobering center in Santa Barbara just 3 weeks before the pandemic hit, and so it was a little bit of a surprise for us all. The original sobering center was funded and continues to be funded by the Board of Corrections through Be Well as well as CalAIM. And that really served to be the hub and the filling the gap that was needed during the pandemic. Many individuals weren't able to really go to jail. It was a great diversion option for them when the jails were shut down, and having them come on the release was really great. So the utilization at the sobering center in Santa Barbara was high due to the pandemic, and so as a result, we started really collecting data and realized that a large percentage of the population we were serving were the homeless population. So we were able to utilize COVID homeless response funding to be able to open a 7-bed sobering center in Santa Maria, which is a northern part of Santa Barbara County. And that opened in April of 2021. And then just recently, about a year and a half ago, we opened up a 12-bed sobering center in San Luis Obispo. Amazingly, these 3 programs are also co-located with crisis stabilization units. So they're at the same locations for all 3 of them. And so if there's an individual that needs a crisis on the mental health side, we're able to refer either across the parking lot or across the hallway, and then be able to bring them back as well if they need ongoing sobering care. The majority of our referrals come from the hospital system, also from partner agencies on both the housing and homeless side of the house, and our other behavioral health partners. And we also do get law enforcement referrals as well. Uh, um, in our system, our CalAIM, which is CalAIM pays for all three of them as well, that CalAIM is under Cal Health, and we've been able to coordinate and partner with them to allow for 3 days of sobering care at each of our locations. So we're super grateful for that. There is not enough withdrawal management beds and residential treatment beds in our county to be able to serve within our counties. And so being able to have the 3 days allows us to be able to triage, connect with Medicaid assisted treatment clinics, which we have, some of them are co-located on site, outpatient programs, and or back into the shelter systems if there's not withdrawal management beds available. The target population for individuals that are under the influence, approximately 70% of the population that we serve are experiencing homelessness. In our admission criteria, they have to be 18 years or older, able to ambulate, non-combative, and it's a voluntary program. And it is a diversion, obviously, for law enforcement as well. Instead of going to jail, they have an option to coming to us. And through the hospital system, they can go ahead and refer to us so we can provide the ongoing sobering care so that other individuals in the waiting room can be able to get emergency services themselves within the hospital system. Our staffing model is always staffed with one medical support staff with a sober coach. In addition, our program manager, all of them are drug and alcohol certified and they're peer support certified. We're looking to, in the next couple months, to be able to provide peer services within the sobering centers and be able to bill for that. So we're excited about that opportunity to be able to make sure that we stay whole. Our funding sources also include opioid settlement funding. We have a little bit of that for the Santa Maria program, and then we also have in the past gotten funding from the local hospitals to be able to support the program as well. Our utilization rate is very high, especially in Santa Barbara. It seems like there's always turnover on the beds and it stays pretty full. Same with Santa Maria. San Luis is growing. It's a newer program, but their numbers are getting up there as well. So we find that it's really, really helpful. We also use it within the homeless continuum of care system. Many of our programs, all of our programs currently are housing first, but instead of discharging individuals from a shelter system because they're not able to maintain their behavior or they're under the influence and it's causing issues, that we can be able to manage them in a sobering center and then be able to bring them back to their bed, which is great. And we do the same in housing programs as well to make sure that people are not going to be evicted, that if sobering care can help them get connected to services that they need, that we do that. And we pride ourselves on really making sure that people have a warm handoff and that they're not just walking out of the sobering center without a plan in place. And so we're grateful for this sobering center. I can tell you, I've been at Good Samaritan for 28 years, and I had no idea that sobering centers were really the missing gap in our systems of care. That's really, truly, I don't know how we survived without sobering care before and sobering centers. And so I'm a huge advocate of the sobering centers and the services that they provide. Thank you.
Thanks so much, Sylvia. I think we can drop the slides now. That was a really comprehensive overview of each of your respective programs. Shannon, I'd love to invite you to share a little bit more. You've done work across California and nationally to really establish the field of sobering centers. Can you share more about yourself briefly and also just reflect on the programs that we just heard and how they fit into or compare to the broader field of sobering care?
Yes, thank you so much, Meryl. And it's really great to be here. And I see so many familiar faces in the chat. Well, at least I see your names, not necessarily your face. So I actually got into sobering care back in 2007, was with the San Francisco Sobering Center. And since then, I now do research on sobering centers. I help consult with communities that are trying to start programs or enhance what they already have. And co-founded the National Sobering Collaborative. So I've been in this world for a long time and absolutely love it. I'd say the biggest, as you just heard, 3 different organizations, variety of different services that can be provided at a sobering center. And just as a quick thing, because I know we want to get into the rest of the Q&A, et cetera, later, is I think one of the greatest benefits of sobering, as you heard here, is it's entirely flexible to the communities that it's serving. What are the individuals in your community? What do they need? What are they experiencing homelessness? Are they primarily housed individuals? is this an area that doesn't have any behavioral health resources at all anywhere nearby that you can help provide some of that gap in addition to care for intoxication? And I think this shared core values, just sticking with the idea of low barrier, open access, 24/7, fills this gap and then provides exactly what the community needs. And lastly, it's super flexible. So you may start off with a program that is working in particular ways to particular populations, and then a new drug comes in the community or a new resource comes into the community on the positive strength side. And then you can wrap around and basically say, we're going to modify literally as quickly as a few days, kind of the services that you're providing. So I'll stop there because I'm loving the questions coming into the Q&A, and I know what Meryl's got popped up here. So
Thanks so much, Shannon. Yeah, we've got some questions teed up and we're getting a ton from the audience. So we're going to try and move through things so we can get to your questions. Um, One of the things that I learned about when I started learning about sobering care is that often there are an array of community partners or cross-sector partners that are supporting these programs. Um, Jamie and Sylvia, thinking back to the formation of your sobering centers, can you describe broadly how that happened and what community partners were at the table in advocating for or developing the program? And Sylvia, maybe I'll start with you on this one, and then Jamie, I'll turn it to you.
Yeah, so the Santa Barbara County was applying for funding through the Board of Corrections, and they wanted to start a sobering center in Santa Barbara. Before this time, our organization was primarily in northern Santa Barbara County. During the pandemic, we expanded greatly down to South County, but it was our first project down in South County, and they got funded. And so through the Board of Corrections, which was filtered through Santa Barbara County, it paid for the sobering center. We initially started as a 10 bed. It's flexed to 12 beds because there's such high utilization at the programs. And then through the process, we were able to also be funded through CalAIM and be able to get certified at that location and provide services. Those that were advocating for the program was really Santa Barbara County Public Defender Tracy McCuga in partnership with Santa Barbara County Behavioral Wellness. And those two organizations really advocated for a sobering center to come into our community and be able to provide sobering care. And then they were able to get the sheriff on board and then other departments and partners as well. I was brand new. We'd never provided sobering care before, a sobering center. And I think that the surprise to me was not only the high utilization, about 60% coming from the hospital systems, and then in addition to that, how many individuals that we were serving that were also experiencing homelessness and the crossover between those continuums of care.
Thanks, Sylvia. Jamie, what about you? I know you have multiple programs, so I defer to you if you want to speak broadly or about one specifically, but can you speak to the formation of your programs and the community partners that were at the table?
Yeah, they all have their really cool stories, as we're hearing on the call today. And I like to think we stand on the shoulders of giants, as they say. So there's a lot of work that goes into getting a sobering started long before a community-based organization bids on a project, right? One good example of that is Albuquerque medical sobering. I mean, I think since 2018, 19, feasibility studies, city council meetings, some pretty challenging city council meetings, debating how the community is going to really benefit from a resource like this. And so there's just a lot of credit, I think, that is worthy of being shared with the momentum makers behind the scenes, those kind of public officials, city council members. For the Cherry Hill Sobering program in San Leandro, it was a board of supervisor that was really a champion for that program and really allocated some funding for those two facilities, the sobering and the detox, to get started. For Butte County, that was last year's grand opening. We had the behavioral health director really just planting seeds for a couple of years before posting the RFP, developing relationships with law enforcement entities. I think there's a lot of wheeling and dealing that has to happen with those community stakeholders. because there's some difficult conversations. Like, let's talk about the share of costs. Let's talk about how you're going to arrange picking up somebody at a sobering center if maybe they bring them to you, a law enforcement officer brings them to you, and then somebody leaves like early against staff advice. There's some debate about which law enforcement entity is going to have to come back and get that person. So a lot of those things really are hashed out behind the scenes long before a sobering center is even opened. So yeah, different stories and a lot of blood, sweat, and tears from the many stakeholders behind the scenes, I have to say.
Thanks, Jamie. Amanda, I'm looking to you. Like, can you speak to the different community partners that support MLK Sobering Center at a high level?
Yeah, absolutely. Yeah, I was not in my position when our sobering center opened. I was, in program management at the time, but now 3 years later, when our sobering center is like really figured out, I feel, what we're doing. It took us some time to get there. Community partnerships are like the central, force that keeps our sobering center operating as well as it does. So because we are part of this bigger like substance use conglomerate, we have automatic community partnerships with other residential treatment centers, outpatient treatment centers, which are huge referral sources for us. We are directly contracted with the county, so the county government was our champion. They were a huge supporter of us. We have partnerships with other local government. Maxine Waters was a big champion of our program specifically. We've had a long-standing relationship with her. And then some more, things that happened further along to our staffing. We even thought about community partnerships when it came to staffing. We partnered with the Amity Foundation to work with their substance use internship program to have their interns come into our program and get that experience there, not only to, provide peer-based services to our clients, but to help with anti-recidivism with the intern population. They pay for these people to go to school and get work experience hours and stay out of incarceration. So that's been a really beautiful partnership. Partnering with the local hospital, that's been huge, and getting the hospital staff to like understand and support and champion the benefit of having a sobering center on campus. It took us some time with the emergency department chiefs to get there, to have them, really understand the philosophy behind sobering care and harm reduction. But now that we have that partnership, it's not just benefiting our program and our clients, but it's benefiting the ED, which is the intention behind this all. We have the LA County Sheriff's Department on our corner. We've done outreach there and kind of ongoing conversations with our, because partnerships with the police department can be both good and bad. And I think we have all experienced that. But having people with lived experience with incarceration working in our systems have been able to go and advocate in ways that I can't with departments of parole and with the sheriff's department, and just really beautiful partnerships we've seen by promoting that community outreach. And I think that's something when planning a sobering center, you have to plan for, is that community integration and community partnership. So those are just a couple of our big partners, but we have so many, and that's really what makes our sobering center work.
Yeah, thanks, Amanda. I want to switch gears a little bit if it's okay. And Shannon, I'm just going to turn to you because when we were talking about this webinar, one of the things that you shared was that sobering centers often fail because of low utilization. And I'm wondering if you can reflect on that statement and what you recommend to sobering centers that want to ensure sufficient utilization of the beds or recliners that they have.
Yeah, that's a great question, and it is a challenge for many programs. One of the things that happens when someone starts a sobering center, and Jamie alluded to this, there's conversations that go on for years prior to this starting. And there's often a number that is developed and said, okay, we have 4,000 people go to jail for this. We have this number of people go to the emergency department. Add that together, divide by 365. That's how many people should go to a sobering center every day. Doesn't really translate that way. So always lower the expectation of exactly how many individuals are going to be served. But I'd say the biggest two things be communicate early and often. So as you're developing the sobering center, get with the community partners that you want to receive referrals from right away. Could be the law enforcement, police department, highway patrol, sheriff's office, etc. In particular, the individuals running the jail, because that makes a huge difference they're going to basically be the other alternative for law enforcement. You want to find out, why are they still going to jail? What brings them there? What can they do to go to you instead? I recommend highly ride-alongs. So leadership who are looking at starting the sobering center, both initially when first starting and once the CBO, the community-based organization, comes in, such as our three partners here, ride along, go in the officers' cars with them, with not just the chief, not just the lead captain, with frontline officers, frontline paramedics, ride in the ambulances with them. What's their day-to-day like? What decisions are they going to have to make if they want to bring someone to the sobering center? Because if you put a certain barrier up or a certain criteria, like, oh, we want everyone to call first, but they don't all have phones. They only use radios. That's going to put a barrier. Your utilization will be low. And the second part is NIMBYism, which I think many people know that phrase, not in my backyard. It is a thing. I highly recommend bringing in the community as soon as possible. Don't make all the decisions, decide what program you're going to have, decide the location, and then let the local community business district know or let community stakeholders know. Because they want to see people get served and helped also. And they also want to make sure their community is safe. And they want to make sure their community doesn't have its housing prices drop. And there's certain things that you can do to make sure that people's fears are alleviated. And so there's less fighting against having a sobering center start. So much bigger conversation, but I'll stop there.
Yeah, thanks so much, Shannon. So just giving the time, I'm going to do something a little bit different because I'm sure that the audience is curious to learn more about each of your respective programs' referral partners. And I'm wondering if we can rapid fire around this virtual Zoom room and have Amanda, Sylvia, and Jamie share just like quickly, who are your main referral partners to your sobering centers? Amanda, can I start with you?
Yeah, absolutely. Yeah, the county itself is a huge referral partner for us. They have a county substance abuse hotline where people who need a specific service call in, get connected to the most appropriate person. The local hospital, given that we're on the Martin Luther King campus, is huge. If anyone has the opportunity to partner with the hospital, that's a huge referral source for us. Our other treatment centers and sober livings, LA County has an R95 initiative right now, so reaching the 95% of people who don't otherwise receive substance use services. So they've really, really encouraged these partnerships. If a client relapses in residential treatment, per se, they used to get discharged, right? Now they come to the sobering center, they can sober up, they can go back into care. And so private sober livings have bought into that model. The county at large is really promoting that. So we get a lot of referrals that way. Word of mouth, walk-ins, returning clients, especially in our county with the large unhoused population, literally at the door of our sobering center. We do have a lot of people who come in for a safe place to sleep at night and sober up. And that's a great thing because at a point they can decide to continue on in care. And even if they don't, at least they're safe. At least they're not dying, right? So we're really big on our word of mouth and our walk-ins. We've partnered with harm reduction providers in the county. We've gone and done walkouts with them. We've done Narcan distribution with some of the local harm reduction providers so that in MacArthur Park in LA County, for example, they can give the people that they serve with street-based medicine an idea to maybe come to the sobering center when you feel you're ready. So that's something that I'm very passionate about. And to echo what Shannon said, like going on those ride-alongs and actually being in the community, partnering with a specific parole officer who you know believes in this stuff, he will start referring people to you. And then our EMS designation being our newest one, getting referrals directly through those emergency service providers. And that's exactly what we did. My program director went on a ride along with the LAFD fire department chief with some of the squads to start getting referrals that way. So that's a rapid fire answer for me.
Thanks, Amanda. Sylvia, I'll turn it to you quickly. Who are your referral partners? And then Jamie, you can chime in, and then I'm going to turn to audience Q&A for the remainder of our time.
So our referring partners, as I mentioned before, is the hospitals. We also serve clean and sober livings so that people don't go back on the streets. We work with residential treatment providers, and we work with law enforcement. We work a lot with the department, county departments, so it's not just Be Well and the sheriff's department, for example, but it's also probation is a big one, in addition to the public defender. The one thing that we have really found that's important important is partnering, and we are the largest homeless services provider, but partnering with the homeless continuum of care for both homeless and housing is critical because many of them are housing first, but housing first came way before the opioid crisis or fentanyl. And so what they're seeing and being able to handle within the shelter systems and housing is beyond their ability. And so being able to connect to the sobering centers, being able to connect to Medicaid assisted treatment and withdrawal management and other services, and being able to keep their beds either at a shelter or housing is really important to be able to keep people off the streets. So those are our main ones. Thank you.
Thanks, Sylvia. Jamie, go for it. Who are your referral partners?
Yeah, I think they covered it, but I mean, I just for context, like pulled up our Mission Street Recovery Station report. We do have monthly reports getting generated out of that program. I see about 45 referral sources for 1 month, right? So that just kind of puts it in perspective. You have a range of law enforcement entities, hospitals, sober living environments, other providers. So, it's just so important. It's almost like you want to think about that connectivity when you're case managing your clients out, right? You're trying to get them the help that they need after they've done their sobering episode, and how well you have those referral pathways, externally speaking, is important in terms of case management. But on the flip side, how well you tether the relationships for your referring parties is equally important when it comes to the success of a sobering center. I can think of one more with a medical sobering center in Albuquerque, New Mexico. So big shout out to Ellen Braden, who really just encouraged us to plug into different referring stakeholders, but way before the sobering started. One of them is Albuquerque Community Safety. So in that region, you have a lot of the 911 calls that will get triaged and routed over to a different division. If it's not as urgent, right, you don't necessarily need to deploy an officer to engage that call and actually head out to meet that person. So Albuquerque Community Safety, or ACS, I mean, they receive so many calls. We did a tour at their facility before we opened, and laying that groundwork really proved useful when it came to opening the sobering center, because they're the primary referral source right now, right? So as they get those 911 calls, they're going out, they're meeting with somebody, they're trying to de-escalate, and then they're making those linkages across the network, and we are one of those linkages in the network. So big shout out to ACS.
Thanks, Jamie. So we've got a bunch of questions. Shannon, thanks. I saw that you started to respond to some of them. So hopefully, folks, your questions are getting answered, even if it's not verbally. I want to start with a question from the audience for you, Sylvia. Quickly, someone is asking if they can understand more about the funding for the 3-day stay at Good Samaritan. How does that work logistic or financially?
So the 3 days is actually covered by CalAIM through Cal Health. So that's our managed care system. And in working with them, we did not have a pilot program with our managed care system or within our county. And so sobering centers were brand new, as were community supports. Good Samaritan was the first provider of community supports in our region. And I also sit on the National Sobering Collaborative with Shannon. And, we had discussions about, there's doing warm handoffs is very difficult in 24 hours when we have wait lists for our residential treatment beds and withdrawal management in our system. So, I mean, the choice is either putting people back on the streets and they show up the next day, or and they have the higher chance of, having something critical happen to them, or we try and keep them for 3 days and get them better connected. And so our managed care system was able to work with the state and have that approved. And so I don't know if there's any others. I know that Skid Row in LA is able to keep them a little longer, but Shannon can probably speak to other programs that have been able to figure out how to have these beds ongoing afterward with different funding streams. But we've been able to get CalAIM to pay for the 3 days within our Good Samaritan sobering centers.
Thanks, Sylvia. There's a really interesting question here from Mary. Thanks for your question, Mary. Mary is asking, how do clients get from one place to the other? Example, from the emergency room to the sobering center. Shannon, I'm wondering if you can just answer this briefly based on your broad experience with sobering care.
And which one was the Mary question? I heard you say it out loud, but
It was, how do clients get from, for example, like the emergency room to the
oh, yeah.
sobering center?
Oh, exactly. So it depends on the community, but the majority of the time, it's a non-emergent transport. So it could be a van service that the community already has for example, transporting individuals experiencing homelessness or individuals going between county services. Some other sobering centers may have their own van. I highly recommend when developing a sobering center, if you can get it with the budget, get a van or some other large vehicle for the sobering center because you will be able to pick people up, drop people off at treatment programs, and that is one way that people do get folks from the ED. Ideally, as Amanda's team is one of the newest ones out there, and Jamie with Albuquerque, getting folks directly from the ambulance into the sobering center is ideal. And the little alt tab to that one is if your community doesn't have the ability for 911 ambulances to go directly to your sobering center, lots of times the ambulance in the field can determine that the person doesn't need an emergency visit stay. And they will often have ambulances that are run by EMT basics, which are they're not 911 ambulances. Those ambulances, which are less expensive, can meet the paramedic 911 ambulance in the field and then bring the person to sobering and avoid the ED altogether.
Thanks, Shannon. So another question from the audience. Thanks, Phoebe, for this question. And I'll open this up to the group just to see if this is a thing for any of your programs. But Phoebe's asking, are the sobering centers able to hold clients longer to ensure inpatient treatment for more than 3 days if a bed or recliner is available? So is there any instance where someone is held more than 3 days if there is space?
I can speak to that. So technically no, but we have clients who discharge for 5 minutes and then come right back in. Or we have clients who transition onto our withdrawal management unit. And I was answering one of these questions in the chat. That co-location is so key for us because 24 hours is the cap for sobering. Our withdrawal management is up to 14 days. So clients can get, up to 2 weeks of care in that environment and then may end up right back in the sobering after. But all that time is more time where they are safe, where they are cared for, where they are clean, where they're treated. So for us, technically, no, 23 hours and 59 minutes is the cap, but we do see clients who leave and come right back, and that's
Yep,
okay. It's a good thing.
us too. Same. Yep.
Thanks, Amanda. Thanks, Jamie. One last quick question from the audience. Robin is asking, do any of the sobering centers, um, does any of the data interact with the regional health information exchanges or HIEs?
Ours don't. It was important for New Mexico. They added that into the RFP. They wanted a provider that had a system that had interoperability. For that reason, you want to share that information with the system so that you can help coordinate care for a client and stuff. But still, in all four of our sobering centers, we don't actually have any of that active interoperability. What about the others?
I don't think
Have you
it's like,
seen that, Shannon?
Yeah, some programs, they don't necessarily share it, but they are in the same electronic health record with the county. So if it's a county funded program, they'll have, for example, Epic, and the sobering center may be able to access it and or potentially put information or notes into the EHRs for the community.
Yeah, that's our model of operation, and the county actually tracks all of that data and manages all of that data directly and uses it to advocate for ongoing funding. So
great. Thank you. And thanks, Robin, for that question. So we are just about at time. I want to thank you all, Shannon, Amanda, Sylvia, and Jamie. This was it was a fast hour that we had together, and there were so many rich insights in your remarks. We appreciate you taking the time to be with us and to share with attendees. You're getting a lot of love if you can see that from the audience. So just quickly before we wrap, Melora referenced this earlier, but there are a number of implementation-oriented materials that CHCF has recently supported that are now out. They're up here on this slide. We encourage you to take a look at those. They'll also be shared out via email with everyone who registered for today's event. you are going to get a pop-up on your screen when this webinar ends for an evaluation. It's very brief. We would really appreciate if you could take a moment to complete the evaluation as it helps us improve our work. If you have any additional questions about sobering centers, we encourage you to reach out to our colleague Mariana Torres at the California Healthcare Foundation. Mariana is supporting a lot of the sobering care work, and she would welcome any questions from you. You're also, of course, welcome to reach out to CHCS if there are any questions that you didn't get answered during today's event. Lastly, thank you again to our panelists. Thank you to the California Healthcare Foundation for supporting this work. To my colleagues at CHCS who are doing a lot of work behind the scenes to make these webinars happening. And thanks everyone for joining us today. I hope you all have a great afternoon and take care. Thank you.